Hi everyone, it's Jo from Plymouth Medical. So sorry I'm not able to be there today, but I'm here in our lab in New York talking to you about cell counting today. We're firstly going to review why it's important to cell count in an orthobiologic setting, and really kind of touch on a number of different ways to cell count today. What type of cell population are we looking for? What do we do with the data once we get it? And really truly what that's going to how that's going to be useful for us going forward. So first and foremost, why it's important to cell count at the point of care in this day and age. Over time, we have been, administering different doses of platelets across the board for a number of different ailments, a number of different degrees of disease state as well. So we're just basically looking to control the controllables, and it just so happens that cell counters actually exist to do that at the point of care rather efficiently. Up until recently, we had different ways to quantify cells, either the old school biology way to, look at, slides and cell count under a microscope. But now we have access to much more sophisticated devices like this Horiba microsystem that can, in less than a minute, provide you 16 parameters on different cell populations that you would find in either whole blood or PRP. So the reason why we want to cell count is because, actually another reason why we want to cell count is because, for the last 15 years or so, the conclusion on a lot of these orthobiologic studies that have been published for PRP and even bone marrow and even SVF have tried to sort of determine, what positive or negative outcome these interventions would have on patients' pain and function. And to date, there's been a lot of sort of inconclusive data out there on the outcomes side. But what we forget is that, a lot of these different commercially available systems like, centrifuge systems and commercially available kits have and produce very different types of PRP at the end of the day. And we actually believe that there is a dose response curve for different indications that exist. So in fact, we have a gut feeling that you really need high counts of PRP or platelets for indications like knee osteoarthritis and disc disease, as well as tendinopathies. But we may actually not need that many platelets if we're treating more vascular areas like the scalp or the dermis. So, but nobody's really determined that because they're not really using cell counting at the point of care. So we really are strong proponents of, quantifying your cells, quantifying the purity of your sample at the point of care. So looking at, that final platelet volume and compare it to the total number of RBCs and white cells, all the different subpopulation of white cells, obviously, just to kind of see whether your PRP is pure or not. So it's one thing to inject a really, really high dose of platelets, but not that great if that high dose of platelets is basically accompanied by a ton of inflammatory red cells and white cells. So there are kits on the market that actually provide, PRP like that. Beyond that, we also want to determine whether the system that you use to quantify or to basically concentrate platelets has been effective or not. And in our opinion, that is why cell counting is so important at the point of care. So this is a hematology analyzer. It basically is FDA cleared to quantify cells up to 4 million platelets per microliter at the point of care for blood-based products. But we also have our total nucleated cell counter right here, the Chemometic device that counts total nucleated cells, or all the cells that actually have a nucleus. And the Chemometic device is also able to quantify cell viability, so whether a cell is dead or alive. So all this to say, our cell counting sort of talk today is really to kind of give you an overview of how you would actually sort of layer this cell counting in your workflows in a busy orthobiologic clinic. So now that we reviewed why it's important to cell count at the point of care, I'm going to basically go through what a typical day looks like running a sample a hematology analyzer like this. So first of all, the components and all the sort of the bells and whistles that come with this device. So this device actually uses 3 different reagents. So these 3 different reagents are in this very heavy pack here. This pack also fits like on the side of the device, like almost like a suitcase, and also acts as a bladder for the system. So any sample that you're putting into the system, it actually gets collected in here. So when 150 cycles of tests are done, this basically can be thrown away in hazmat. Beyond that, being in this device actually is used in hospitals all over the world to diagnose a number of different ailments like sepsis. We want to be sure that the device is actually throwing out accurate counts. So every 2 months, we'll basically send you pre-calibrated samples of blood that need to be refrigerated. So the low, medium, and high samples have a known quantity of all different blood components, from RBCs, monocytes, lymphocytes, platelets as well. So we're gonna run these controls on the device by basically using a barcode reader, or just enter the actual value as well. And the device is actually preloaded with those counts. So if the machine's not in control, it's not gonna let you run samples. And that's for the reason of we don't wanna get really bad counts from a device, whether it be to diagnose sepsis or whether it be to quantify PRP and how many cells you actually injected in your patient. Today we actually created pure PRP from a 30 ml sample of blood. We spun it 2 times, we followed our protocol, and we created what we think is a neutrophil poor, monocyte-rich, platelet-rich PRP. Sample this in is a KEDTA microtainer. We sort of open the microtainer, we pop a couple drops in as all this needs. The device actually only takes 10 microliters of sample, so it's really nothing. We do recommend at least 2 drops, which is 50 microliters in this little microtainer to run a sample, in case you have to do, triplicate tests, or really so that the probe that comes down from the device has enough volume to sort of sample. So I'm gonna basically run a sample right now for us. What I'm doing is I'm making sure that the specimen is completely resuspended, so that the solution or the cells that are being counted are all evenly dispersed through the actual PRP that we're testing. Because if this is sat for a number of minutes or hours, it'll basically it will basically settle out of solution, and we want to be sure that we're counting the cells and not just plasma. Okay, so I basically entered in the name of the sample, pure PRP. I'm happy to run that, and then now I'm going to basically run the sample and get it going. So in a minute we're going to get an actual result from this, and I'll be back as soon as that happens. So the analysis is complete, and what we can tell from this sample is that the final PRP count or platelet count was close to 882,000 platelets per microliter, which is a concentration above baseline. Obviously, all of us have on average 150 to 450,000 platelets per microliter. In this case, the patient's baseline blood, which we also characterized, is at 144,000 platelets per microliter, so on the very low side of platelet counts to start with. And all of the different values from this analysis will really clearly show that the final PRP sample was mostly depleted of all RBCs. So we went from close to 43% hematocrit down to 0.4% hematocrit. So the process itself was very efficient at removing RBCs from the PRP sample. In this case, our assumptions were correct. We concentrated monocytes and we depleted the granulocytes, or the neutrophilic cells, those inflammatory white cells that upregulate inflammation. So definitely do not want to be using neutrophils in someone's joint or someone's spine. So we depleted that in this process, and with all these different sort of data points from both baseline and PRP sample, we'll be able to kind of determine what the X factor was. We'll be able to determine what the total dose of platelets were administered to the patient, and 4 mLs of PRP. And we'll also be able to determine really what type of PRP we actually injected. What classification are we going to attribute to this PRP? In this case, we like to use the DEPA classification that Dr. Magellan and his team in Marseille published on several years ago. So we'll be able to sort of assign how pure the sample was, what the dose of platelets was, how efficient our process was at basically taking the platelets out of the whole blood and concentrating it. And in this case, whether the PRP was activated or not upon injection with either calcium chloride or calcium gluconate or a thrombin product. So all that to say, this data and the cell counting will give us a lot more information on what was actually injected, so then we can take that cell quantity, take that classification for the PRP and tie it to patient outcome, so we could start making better correlations with how patients are doing over time. And ultimately, what we believe this is going to sort of yield is a much better understanding of what that dose response curve is for different indications. So do we really need to get 8x PRP for avascular, regions like a joint or a tendon, or do we actually need a little less PRP to get the aesthetic treatments that we're, the aesthetic outcomes rather that we're looking for in dermal rejuvenation? So the dermis, obviously being that it's more vascular than a knee joint, may actually benefit from a lower dose of PRP versus scalp injection. So all this to say, that's why we need cell counting at the point of care, and I hope that provided you with a good overview of how the device actually works.